Hello, Professor and fellow classmates. My name is Jerry Schramm, and my presentation is on the health system of Thailand. The country Thailand covers geographically 513,120 square kilometers. You see a map of it there. It shows that there are quite a few countries that border Thailand on various sides as it drifts down through the peninsula. There's Indian Ocean on one side, the Gulf of Thailand, and the Andaman Sea on the other. Thailand's population in 2010, the population was 62 million. A majority was located in the capital city of Bangkok. In 2009, 25.9% of the population was under 18, and in 2009, 7.8% of the population was over the age of 65. So there is a predicted negative growth in those between the under the age of 14 beginning in 2015. Growth rates will reach negative numbers in 2020 for those 15 to 64, and the population over 80 will reach 3% by 2030. So it's apparent that the population is growing old, but they're not reproducing as quickly as they had in the past. The average life expectancy of males has also increased to 69.9 years of age, and in 2007 the average life expectancy of females was 77.6 years of age. Thailand's economy has been doing well. It saw a per capita increase from 25.68 in 2000 to 44.30 in 2008. 57% of the population had lived in poverty in 1960, but that rate had dropped to 11.3%. And in 2008, a total of 4.9% of the GDP was spent on healthcare as the economy grew, as well as the adoption of a universal healthcare model in 2001 basically it justifies the 4.9%. The history of the healthcare system. So prior to adoption of the universal healthcare scheme of today, Thailand had a medley of insurance options that left a majority of the population without appropriate coverage. The civil servant medical benefit scheme, social security scheme, the workman's compensation scheme, medical welfare scheme, and the Type B exception scheme were all options prior to universal health coverage. So in 2001, the Thai Party was elected into office. They ran on the platform of improving healthcare. This change, however, initially was the road was paved in 1997 with the administration of public services shifting over to local authorities. The Thai Party made the Ministry of Public Healthcare expansion a reality. The ministry had a mindset of a program, a 30 baht program, where it would cost 30 baht in order to provide each person with health care. That was the design scheme. As the primary healthcare and secondary healthcare had been established under the local authorities, the resources were available. The shifting and the reimbursement was the structure that was implemented by the Thai Party. In 2001, quarter of the population lacked health coverage. 17,000 children under 5 died, and 20% of low-income citizens were impoverished due to health care costs. The Thai Party used their political power to swiftly enact change. The new health care model was quickly put in place, with all provinces included by October 2001. Through collaboration with representatives in the community, the healthcare initiative was successful. They already had primary and secondary healthcare processes in place, as I mentioned, and that assisted in the adoption of the universal system. It was built off the current structure in the community, utilizing and enhancing the current resources available, such as the healthcare volunteers. In 2001, prior to adoption of the universal healthcare scheme, 30% of the population was uninsured. By 2002, that had increased to 98% of the population. Thailand's basic health system. So prior to 2002, there were 4 total health schemes: civil service medical benefit scheme, low income care scheme, voluntary health care scheme, social security scheme. After 2002, that was consolidated into three systems: the Civil Servant Medical Benefit Scheme, Social Security Scheme, and the Universal Coverage Scheme. So the Civil Servant Medical Benefit Scheme covers the government employees and dependents. Social Security Scheme is for employed workers, and it's supported and funded by a 1.5% payroll tax. The Universal Coverage Scheme covers all the remaining ties, and it's funded by the government. There is private health insurance, but it only accounts for 4.7% of the health expenditure in 2004, but there is evidence that private health insurance has increased and certainly has likely a larger portion than 4.7%. In 2014, 8.01% of the population was enrolled in the Civil Servant Scheme, 12.9% in the Social Health Scheme, and 74.6% in Universal Coverage. The initial cost to use Universal Coverage was $1 American, but became totally free in 2007. So accessing the actual healthcare system. It's designed as a pyramid, consists of primary care units or health centers, district hospitals, regional hospitals, and specialty centers. The primary care units are the first point of contact. They provide curative care, health promotion, disease prevention, rehabilitation. They're generally staffed by nurses, primary care workers, paramedics in many cases, and occasionally by a doctor, and they serve a population of about 10,000 to 15,000 people. From what I can gather, these are similar in comparison to an urgent care that we use today. District hospitals, they're staffed by doctors and health teams. They serve a population between 50,000 and 200,000 people. They're a link between primary care centers and regional hospitals, and they're tasked with referring patients who need increased resources that would be found at the regional and specialty hospitals. Due to Thailand's insurance, reimbursements providing capitated payments versus solely fee-for-service, as had been done in the past, beneficiaries are required to register with the qualified provider in their district. To become qualified, the provider needs to become CUP, which is contracting units for primary care. And in doing that, they'll receive capitated patients based on subsequent volume of patients seen, but they must petition to become CUPs. Outpatient care is provided to the CUP through capitated payments, and inpatient care through diagnosis-related group formulas. As I went through all of my research, there was quite a bit in each of my references related to CUPs and explaining in depth how the reimbursement structure is done. Basically, from what I can gather, the idea is that you'll register as a CUP and you'll become a place where people can go in your particular area. They register with you, they seek their service with you, and then the more quantity you turn, the more capitated payment you get. Basically, if you look as an example, you may get $200 per patient seen. Regardless of how much is involved in taking care of that patient, you get $200 per patient. So the idea is to register patients, become a CUP, register patients, and see those patients, care for those patients, and keep your costs contained so that you ultimately receive, you have a margin with the capitated reimbursement you receive. An additional layer of health access is the Village Health Volunteer Program. It's been in place since '79. It's respected in the community and in the healthcare system. It provides for maternal child health, prevention, control of communicable diseases, and supported by the local government. There's non-financial incentives that are provided in lieu of money, such as free healthcare training for family members and such. These are basically health providers in the community who have health training, and they're able to provide service at a lower scale in rural communities. There are positives with the Thailand healthcare. As of 2011, Thailand's healthcare cost approximately $80 per person. It decreased worker sick days, reduced financial burden on families. The life expectancy increased in males from 56 to 71. It increased in females from 62 to 80. Hypertension, cardiovascular disease declined by 29% over 7 years, which is huge considering that as life expectancy increases, so will chronic disease and chronic disease management. Hypertension, cardiovascular disease are certainly some high risk factors as you age and with chronic diseases. So the point that they've reduced it by 29% is certainly admirable. Reduced maternal mortality from 374.3 to 9.8 per 100,000 births. Reduced infant mortality from 84.3 to 11.3 per 1,000 births. Reduced under 5 mortality from 12.8 to 12.4 per 1,000 births. And reduced HIV mortality from 27 deaths to 6 per 100,000 people. So some substantial improvements in overall healthcare. Several additional positives is that more people have access to more care under this system. Free prescriptions, outpatient, hospitalization, disease prevention, radiology, surgery, and critical care. Very well-rounded healthcare insurance. 2012, 99.9% of the Thai population had access to health coverage. There was also noted improvement in 2-year survival from cancer and heart attack. Again, huge when you consider that a population that now lives longer will develop more chronic diseases. So the ability of addressing those diseases, still managing cost under a universal system, is certainly admirable. Once again, more disease detection and prevention with diabetes, hypertension screening, as well as smoking, body mass index, and alcohol consumption risk factors are all key initiatives to, again, managing those chronic diseases that are seen, and the fact that there is universal health coverage provides reimbursement to do that. The negatives of Thailand's healthcare: cost containment. As I've mentioned time and again, that there's benefit in providing care. However, the population is now increasing in age because of the care that's available to him. As the care becomes available, the chronic diseases become increased, and as that increases, the cost to provide care for those increases. The total national healthcare expenditure increased 7.7% from 1980 to 2005, faster than the GDP. When you consider universal healthcare went into effect in 2001-2002, you can understand how that's increasing. The per capita increase from 2000 to 2005 was 20%. And then you have 3 different healthcare schemes with different reimbursement designs and administrative functions, and that can certainly lead to unnecessary costs. Some additional negatives: an aging population, chronic disease. I've mentioned this. It increases the healthcare cost. Rural areas have less healthcare access than urban areas. Difficult to include additional services to address emerging health issues from chronic disease. This is basically as diseases progress, managing those diseases become more complicated. So if a new process, perhaps there's a new form of cancer that is diagnosed and there's a new treatment option that's available, being able to include that as a coveraged option with the added financial costs that would associate with that can certainly be challenging when you're trying to manage patients on $80 annually. So it is difficult to try and include additional healthcare advances that become available. Prescription drug cost increased from 32% to 43%. Air pollution is an issue in Thailand. The particulates are associated with morbidity and mortality. Population shift, moving towards urban areas. It's seen in urban areas that hypertension, diabetes, obesity, cholesterol, and CAD are also higher. So as the population moves more into the urban environment, you would assume that those chronic diseases are going to increase as well, which would in turn then tax the system even further. Competition for qualified workforce with the private industry. That's a problem we see, I think, in more or less every country we've studied thus far. And lost reimbursement from higher paying patients to private industry. Again, a challenge that we've seen throughout this course. So in conclusion, for a country ranking 104th in gross national income, Thailand has implemented a universal healthcare scheme, something that many other middle-income countries have struggled to achieve. So that's by all means admirable. The design is functional, it's effective. However, without more focused attention with disease prevention, education, the chronic disease will quickly increase to levels that are unsustainable under the current system. Through unification of the 3 healthcare schemes into one complete universal coverage option, the cost may be better controlled, not only in reimbursement but in the funding sources and administrative efficiencies as the funding is channeled into one direction. Capitated payments replace fee-for-service, and you have more economies of scale. Obviously, the cost can certainly be controlled much easier. These are my references. And of course, as a paramedic, I would have to end with an ambulance from Thailand. So I hope you enjoyed my presentation, and I enjoyed presenting it. Thank you.